Welcome to the deep dive. Today, we're diving into a really fundamental but honestly quite challenging topic in ophthalmology, the red eye.
Absolutely. It comes up all the time.
Yeah, so our goal here is to cut through some of that complexity, pull out the essential bits, and give you, especially if you're an ophthalmic resident or a final year med student, a solid framework for when you see these patients.
Sounds good. It's
Yeah.
definitely something you need a clear approach for.
Let's unpack it.
Okay, so the red eye. Probably the most common reason someone shows up needing urgent eye care
Right.
and learning to quickly tell apart, the benign stuff from the potentially sight-threatening. That's just crucial, paramount, really, for anyone on call or in clinic.
Totally. It's not just seeing red, it's figuring out why it's red.
Exactly.
Yeah.
Decoding that sign.
And the stakes can be, well, incredibly high. Let's paint a picture. Imagine this patient walks into your clinic.
Okay.
Severe pain, really red eye. And they tell you their vision suddenly dropped. Significantly. You look closer, maybe see some swelling around the eye, it could be some discharge. And when you ask them to look around, it clearly hurts them to move the eye.
Okay, yeah.
Yeah.
Alarm bells should be ringing loud and clear there.
That's the one, right, the red flag patient.
Absolutely. That patient you've just described, severe pain, vision loss suddenly, painful eye movements, maybe swelling, even proptosis a bit.
Proptosis, yeah, the eye bulging.
That combination is screaming sight-threatening emergency.
Yeah.
This isn't your run-of-the-mill conjunctivitis.
Definitely not.
You need to act fast, figure out what serious problem is lurking behind that really angry-looking eye.
Okay, so let's back up just a bit. Establish the basics. Red eye itself, it's not really a diagnosis, is it?
Correct? It's a sign. Just means there's injection, dilated blood vessels somewhere on or around the globe.
And the type of redness matters.
Huge clue. Are the vessels superficial, bright red, all over, like in conjunctivitis? Or are they deeper, maybe a bit purplish, perhaps only in one sector? That might point towards the episclera or even the sclera.
Ah, okay, so different layers involved.
Exactly.
Right.
Conjunctival, episcleral, scleral vessels, which ones are involved, helps narrow things down right from the start.
And the list of possible causes is just huge, from simple irritation to really serious infections or inflammation.
It really is enormous. So I think the best way to approach it is anatomically. Kind of work our way from the outside in.
Makes sense. Where do we start? Eyelids.
Yep, eyelids and adnexa. Think about blepharitis first. Super common.
Inflammation of the lid margins, right?
Yeah.
Scales, crusting.
Exactly. Greasy debris sometimes. That definitely causes irritation and redness. Then there's dry eye, a massive cause of red, uncomfortable eyes.
Always comes up.
Always. It's often a problem with the tear film layers, lipid, aqueous mucin. If that tear film isn't stable, the surface gets irritated red. And don't forget dacryodinitis.
Inflammation of the lacrimal gland.
Right, up in the outer part of the upper lid. Tender, swollen gland there. Causes redness for sure.
Okay, moving slightly more onto the eye itself, the conjunctiva. Probably the most common culprit overall.
By far. Conjunctivitis is the diagnosis you'll make most often. Viral is number one.
Watery discharge, maybe some follicles.
Usually, yeah. Those little bumps on the inside of the lid.
Yeah.
Bacterial tends to be thicker, more purulent discharge. Allergic. Itching is key, often with bigger bumps we call papillae.
Right.
But you've got to remember other things too, like chlamydia conjunctivitis. Often see that in younger adults. Can be unilateral, lots of follicles, lid swelling, discharge, and crucially, check for a preauricular node.
Ah, the little lymph node in front of the ear.
Exactly. And for contact lens wearers, giant papillary conjunctivitis or GPC. That's mechanical irritation from the lens causing those big papillae.
Okay, now onto a really critical structure, the cornea.
Yes. Normally clear, no blood vessels except right at the edge, the limbus. Any redness linked to the cornea is automatically a bigger worry.
Like keratitis.
Keratitis, yeah.
Yeah.
Inflammation or infection of the cornea. This is a major cause of painful red eye and potential vision loss. Bacterial keratitis often comes with an ulcer.
A visible defect.
Yeah, an actual defect you can see, often with a white infiltrate, usually linked to contact lenses or trauma. Needs aggressive treatment, often fortified antibiotic drops.
What about fungal?
Fungal keratitis. Trickier to diagnose, harder to treat. Often after getting hit with like a plant branch or an immunocompromised folks, you absolutely need cultures. Viral is common too, especially herpes simplex.
The dendritic ulcer.
That classic branching pattern you see with fluorescein stain.
Yep.
And then there's the nasty one, acanthamoeba keratitis.
Ah, Yeah, heard about that one. Pain is severe.
Excruciating pain, often way out of proportion to what you might see initially. Strongly linked to soft contact lens wear and contaminated water, tap water, hot tub swimming pools. You do not want to miss a xanthamoeba.
Wow. Okay. And simpler things like corneal abrasions or foreign bodies, they cause redness too, right?
Absolutely. Painful red eye. And don't forget exposure keratopathy.
When the lids don't close properly.
Exactly. Maybe from thyroid eye disease pushing the eye forward, or a facial nerve palsy, the cornea dries out, or neurotrophic keratopathy where the cornea loses sensation, becomes vulnerable.
Got it. Okay. Going deeper now. Sclera and episclera.
Right. So episcleritis is pretty common, usually benign. Inflammation just under the conjunctiva causes redness, maybe sectoral, mild discomfort, but usually not real pain or vision loss.
Okay. And scleritis.
Scleritis is the serious one. Inflammation of the actual sclera, the tough white wall of the eye, often causes this deep, boring ache. The eye might look kind of dusky red, and it's frequently linked to systemic autoimmune diseases.
Like rheumatoid arthritis.
Exactly. RA, lupus, vasculitis. A key sign can be tenderness if you gently palpate the globe through the closed eyelid. Much more tender than episcleritis or conjunctivitis. Making that distinction is vital.
Okay, now let's go inside the eye. Anterior chamber, uvea.
Right. Inflammation inside the eye involving the iris, ciliary body, or choroid, that's the uveal tract. We call it uveitis.
Anterior uveitis being the most common.
Yes. That's where you see inflammatory cells and protein, what we call flare, floating in the anterior chamber. You need a slit lamp to see it properly.
Yeah.
Causes redness, significant light sensitivity, photophobia, pain, often blurry vision.
And the causes.
Can be non-infectious, linked to systemic stuff like certain arthritides or Behçet disease.
Yeah.
Or it can be infectious, think syphilis, sarcoidosis, TB, even CMV, especially in immunocompromised patients.
And the most severe infection inside the eye.
That would be endophthalmitis, an
Yeah.
absolute ophthalmic emergency.
Usually after surgery or trauma.
Often, yes. It's a bacterial or fungal infection right inside the eye. Presence typically with sudden severe pain, dramatic vision loss, a lot of lid swelling, and chemosis.
That's the really swollen, jelly-like conjunctiva.
Exactly. And often a hypopien, that visible layer of pus in the bottom of the anterior chamber. If you suspect endophthalmitis, time is truly sight. You have to act immediately.
Okay. What about problems involving the orbit, the structures around the eye?
Also critical to pick up. Orbital cellulitis infection behind the orbital septum. Remember our initial patient.
Yeah, pain with movement, restricted movement.
Decreased vision, maybe proptosis, maybe even an RAPD, that pupil defect, that's orbital cellulitis, until proven otherwise. Usually linked to sinus infections, needs 5E antibiotics, maybe surgery.
And that's different from perceptal cellulitis.
Totally different. Perceptal is infection in front of the septum. So lid swelling, redness, yes, but no proptosis, no painful eye movement, no vision change, no RAPD. That distinction is a really key diagnostic step.
Got it. And things like idiopathic orbital inflammatory syndrome.
IOIS, yeah. Can mimic cellulitis, but is inflammatory, not infectious. Needs different management, often steroids.
And we should always keep systemic diseases in mind too, right? Lots of connections.
Definitely. Like we said, rheumatoid arthritis and scleritis. TB, syphilis, sarcoidosis, Behçet's, and uveitis or vasculitis. You even have to think about things like giant cell arteritis in older patients presenting with headache, jaw pain, maybe some vague redness, especially if their vision is affected due to AION.
Anterior ischemic optic neuropathy.
Right, and even rare but devastating stuff like cavernous sinus thrombosis, maybe from a facial infection causing major proptosis, paralysis of eye muscles, redness.
And finally, we can't forget post-op complications.
Huge category, especially now with so much refractive and cataract surgery. After LASIK or PRK, you can get infectious keratitis or inflammatory reactions like DLK.
Diffuse lamellar keratitis.
Yep. After cataract surgery, some uveitis is common, but the big fear is always endophthalmitis. Any red eye after recent eye surgery needs careful evaluation.
Wow. Okay, that's a lot of possibilities. So how do you actually sort through all this when that patient is sitting in front of you? Back to our worrying case.
It really comes down to your history and your exam. They are your best tools. History is gold.
What are the key questions?
Onset, sudden or gradual. Pain, what kind of pain? Scratchy foreign body feeling, sharp, dull ache, deep, boring pain, or specifically pain when moving the eye, vision changes, light sensitivity, discharge type, and crucially, contact lens wear.
Gotta ask about contact.
Always type where schedule, hygiene, any water exposure, recent trauma, recent surgery, then systemic symptoms, rash, joint pain, fever, fatigue, jaw claudication, weight loss, and their past medical history, autoimmune diseases, diabetes, hypertension, STIs, all relevant.
Okay. And then the exam. Which findings really push you towards those urgent diagnoses?
Right. First, visual acuity, always. Sit down. Red flag number 1. Then pupils. Check for an RAPD. Suggests optic nerve issue or severe posterior segment disease. Then eye movements, full and painless, or restricted and painful. Any proptosis. Significant swelling around the eye.
And looking closely at the eye itself.
Look at the conjunctiva. Pattern of injection. Chemosis, that's severe swelling. Discharge type. Then the cornea. Absolutely essential. Use fluorescein stain. Is there an abrasion? A dendrite. And infiltrate that white spot suggesting infection. Check corneal sensation too. Reduce sensation points towards neurotrophic problems.
And into the anterior chamber.
Slit lamp exam needed here. Look for cells and flare the hallmark of uveitis or internal inflammation. Is there a hypopyon, that layer of pus? And check the intraocular pressure, the IOP. Can be high or low depending on the
Oh, don't skip the back of the eye.
Never. Dilate if you can. Look at the optic nerve. Is it swollen? Check the retina for inflammation, detachment, vasculitis. Gently palpate the globe through the lid. Is it tender? Palpate the orbit. Putting all these pieces together, history and exam, that's how you build your differential.
So for our initial patient, severe pain, vision loss, painful movement, swelling, where are you focusing your differential?
With that combo,
Right.
top of the list, severe keratitis, maybe bacterial or acanthamoeba, scleritis, especially if the pain is deep and boring, uveitis if there's significant inflammation, orbital cellulitis, given the pain with movement and potential proptosis vision loss,
Right.
or endophthalmitis, especially if there's a hypopyon and recent surgery trauma. Those are the urgent ones you have to rule out or in.
Okay, so you have your likely candidates. How do you confirm? What's the workup?
It's tailored to what you suspect. Infection high on the list, keratitis, endophthalmitis, cultures are key.
Right.
Corneal scrapes, maybe AC or vitreous tap for endo, culture of the contact lenses, and case if worn.
Right.
Suspect orbital issues like cellulitis, tumor, IOIS,
Right.
parvenous sinus thrombosis. You need imaging CT or MRI of the orbits and brain. Essential.
And labs for systemic causes?
Yeah. If you're thinking scleritis, uveitis, GCA, you'll order labs like ESR, CRP, ANA, RF, maybe syphilis testing, VDRL or RPRFTA, ABS, ACE for sarcoid, a CBC, maybe PCR testing on eye fluids for specific viruses in some uveitis cases.
And management obviously follows the diagnosis.
Exactly. Target the cause. Antibiotics for bacteria, often intensive topical fortified drops for bad keratitis, IV for orbital cellulitis, intravitreal injections for endophthalmitis, antivirals for herpes, antifungals for fungus.
What about managing the inflammation itself?
Steroids are used a lot. Topical steroids for uveitis, some keratitis, post-op inflammation, but you have to be careful.
How so?
Use them with extreme caution, or often not at all, if you suspect certain infections, like active herpes keratitis or untreated bacterial keratitis. You can make things much worse. Systemic steroids might be needed for severe scleritis, IOIS, GCA, some uveitis, and immunosuppressants if there's an underlying systemic disease driving things like scleritis or Bisset's.
And supportive care, things to make the patient more comfortable.
Definitely. Cycloplegic drops, they dilate the pupil and relax the ciliary muscle. Helps a lot with pain from spasm in uveitis or bad keratitis, and prevents the iris sticking to the lens, which we call synechia. Lubricants for dry eye or exposure, maybe patching or a bandaged contact lens for some corneal issues.
And sometimes surgery is needed.
Sometimes, fixing eyelid problems, dealing with non-healing ulcers, draining an orbital abscess, or vitrectomy with antibiotics for endophthalmitis, and always treating the underlying systemic condition if one exists.
This framework is really, really helpful. If there's one high-yield pearl, one sort of shortcut for residents and students when they encounter a red eye, what would it be?
Okay, the single most important filter, I think, is this. If a patient has a red eye, but their vision is normal, they have no significant pain, especially not with eye movement, no proptosis, no RAPD, and their cornea looks clear without an infiltrate, and there are no obvious cells or flare in the anterior chamber, then it's unlikely to be one of those truly immediate sight-threatening emergencies.
That's a great practical filter.
It is. But the flip side is just as important. The presence of any of those key signs, decreased vision, pain with movement, proptosis and RAPD, a corneal infiltrate or ulcer, or cells and flare that should immediately set off alarms.
And point you towards
Those urgent conditions. Severe keratitis, uveitis, endophthalmitis, orbital cellulitis or scleritis. Those are the diagnoses you cannot afford to miss. So the shortcut is really knowing those red flag signs cold.
Fantastic. That was a really focused deep dive into the red eye. We've covered the anatomy, the huge range of causes from front to back, and most importantly, how to spot those critical warning signs.
Yeah, it's all about having that systematic approach and knowing what signs demand urgent attention. It really makes all the difference in managing these patients effectively.
Absolutely essential skills. Keep that framework in mind next time you see that red eye patient. That's a wrap. Stay focused, keep learning, and subscribe.